cancers by the wisdom of knowledge, as the science and technology and modern medicine has led us to a great longevity of human beings, so will this knowledge. And if the knowledge is kept to oneself and not imparted to others, it becomes just a garbage. And so we have these webinars to spread the knowledge to all the doctors, and many should benefit from this learning and update their knowledge about skin cancers from the great stalwart Dr. Surbhi. And for that, I would like to call upon Dr. A.K. Chaturvedi, who is the co-founder and proprietor and owner of Dr. Chaturvedi Cancer Hospital and radiation oncologist in himself and past UPARI president. Over to you, Dr. A.K. Chaturvedi. Please give introduction about Dr. Surbhi.
Thank you, Dr. Dipti. Today's very important topic, skin cancers. These cancers can be easily diagnosed because they are superficial. It can be visualized by naked eye. But the question is, you have to know how it looks like. And then only you can catch it in the early stage and you can treat it and you can get cured. And because of ignorance, people just don't go for it, for the treatment, and they suffer. Otherwise, it is curable cancer. And on this topic, we have got a learned speaker, Dr. Surbhi Gupta. As you all know, she is a well-known radiation oncologist. She is head of department, SN Medical College, Agra, Department of Radiotherapy. She has done her MBBS, MD, DNB, Gold Medalist, and MNA, MS. She is Secretary General of UPARI. She has got Malala Award, Hindustan Times 2015, Lady Doctor Award, Women Achievers Award, Amar Ujala Award, Virangana Award by Dainik Jagran, Dr. Ajay Agrawal Award for Lady Doctor UPIMA 2019, Women Empowerment Award by local organizers, and so many more awards. She has got 30 research papers in international and national journals, PG thesis guide, special interest in carcinoma breast, hypofractionation radiotherapy, and intraluminal brachytherapy. She is very much socially active, and she is taking active participation in cancer awareness programs, including lectures in school and colleges, attached with various NGOs for social work, active Rotary Club member, conducted No Matlab No campaign against tobacco. This is very important campaign, No Matlab No. Nahi lena matlab nahi lena. So this is very important. She is associated with that campaign. So Dr. Surbhi, over to you for your presentation regarding cancer skin.
Thank you so much, sir. I'm audible? I'm audible. Hello?
Okay.
Yes, ma'am. Yes, ma'am.
Yeah. So very good evening to each and everyone present here. And thank you so much, Dr. Dipti and Dr. Chaturvedi, sir, for giving this opportunity to give an overview over the malignant skin tumor. I will try to give justification with my topic. I can see that most of the PG students are here. So this is just an orientation program regarding the skin surgeon. It's not a substitute of chapter. So starting with, let me start with the anatomy of the skin. Basically, everyone knows that the skin is made of the epidermis and the dermis. Epidermis thickness varies from side to side. When we talk about the eyelid, it is very thin, it is 0.05 millimeter, while over other side it is about 1.5 millimeter. Epidermis has the 5 layers: stratum corneum, lucidum, granulosa, spinosum, base cell. And below this is the dermis part, which has the two parts, that is the papillomis and the dermis reticulum. Below dermis is the hypodermis. We can call it subcutaneous tissues and all other things are. Yeah. This is the cross-section of skin. You can see that the squamous cells lies on this part, while the basal cells form the basic lowermost part of the epidermis. And melanocytes are present. These are the cells which are present under the basal cells. So this is all about the anatomy of the skin. Now coming to the function, skin, everyone knows that it acts as the protection of the internal organ. Apart from this, it also a sense organ. This is the largest sense organ, causes the heat regulation, absorption, secretion, excretion, and apart from this, vitamin D production. So this is the basic thing. Regarding epidemiology, I will say that we are very lucky that in Southeast Asia, incidence is very low of carcinoma, while in case of the Western Pacific region and the Americas, it is the foremost, most common carcinoma found in male as well as female. There are various types of the skin carcinoma, but the three most common which I will talk about here are squamous cell carcinoma, basal cell carcinoma, and melanoma. Apart from this, Merkel cell carcinoma is also there. It is a kind of the neuroendocrine tumor. So starting with the basal cell carcinoma, it is the most common cancer found in the human, and it is estimated that near about more than 3 million patients are newly diagnosed in USA. Males have the more propensity of developing this skin cancer. It is said that higher the age of the exposure, the higher the chance of the developing skin cancer. So it is commonly seen over the age of 6 years, usually seen in the head neck area, but it can occur at any site where the skin is there. Coming to the risk factor, ultraviolet rays, whether it's A or B, is the most common risk factor of developing basal cell carcinoma. People with light skin, light eye color, people with northern eastern ancestry who has the inability to tan. Even it is rare in the dark skin. It is general concept that melanin or the melanoma dispersion in the skin causes the photoprotection. Sun damage, repeated exposure to sunburn, red hairs, even if a black person is having the red hair, it also has the propensity of developing the basal cell carcinoma. Any person is having any previous injury, cutaneous injury, it may be in the form of the thermal burn, it may be the cutaneous lupus disease or sebaceous nevus. These are all risk factors which causes the incidence of the basal cell carcinoma. Etiology. Basal cell carcinoma is multifactorial. We cannot say that this one is the only factor which causes the basal carcinoma, but it's generally said that ultraviolet radiation causes some genetic change, DNA mutation in the PTCS, tumor suppressor gene, and which ultimately causes the change in the health of signaling pathway, the most common pathway for development of the BCC. Apart from this, there is spontaneous and inherited gene defects which causes BCC. BCC means basal cell carcinoma. So, what are the clinical features? Any skin lesion which is not healing in spite of local medication and it persists more than 2 weeks, it should raise the suspicion of skin cancer, whether it's maybe the BCC or maybe squamous cell carcinoma. Usually it is found on the sunspot site, head neck, it's constituting about 60%, nose 14%, even in extremity it is 10%. The common feature of the BCC is that it is a translucent type of the tumor. Many times it is associated with ulceration. Over the skin of the lump, you can see the telangiectasia and the roll border. So characteristics differ from different clinical subtypes. There are the various subtypes. I will give a small overview of each type. This is a nodular. You can see here that it is a nodular type of the lump which has the tender ulceration. There is a disturbance in the background. I will request host to kindly mute them. Now, you can see that this rolled out border around the ulceration. This is the characteristic of BCS, and usually telangiectasia also seen. It is also called a rodent ulcer. Why it is rodent? Because rodent means to mouse. It has the propensity to invade. So it is an invading type of the tumor, and it is an aggressive variant, nodular variant. So it is called rodent ulcer also. Pigmented, you can see that it is a nodular, but the pigmentation is there. So many times it is confused with the malignant melanoma, but translucence is present here in BCC cases. Superficial BCC, it is usually confused with the dermatitis. So if there is a long-term dermatitis, it is not being cured, is not being healed after taking the treatment more than 2 weeks, then suspicion of the superficial spreading BCC carcinoma should be in the mind. Morphea type, you can see here that it is looking like there is some scar, and over the scar there is a lump. So if there is this type of the growth present, which is hardly white and superficial telangiectasia is present over it, and patient is not giving any history of the trauma or the scar over it should raise the suspicion of the morphea variant, and it is a very aggressive type of BCC. Basal-squamous, as its name is already depicting that it has the dual properties of the squamous as well as basal cell characteristics in contiguity. It is also an aggressive type of BCC. This is the fibroepithelioma pincus, usually seen on the trunk area, very well demarcated, usually pink in color, which is called the pincus fibroepithelioma. Now, coming to the diagnosis, how to diagnose? If any such type of skin lesion comes to any physician, first of all, complete skin examination is mandatory because these type of the patient has the many concurrent skin lesions along with his primary lesion, and these patients also has the propensity of developing the malignant melanoma. For the confirmation, biopsy is advised. There are the many types of the biopsy. Usually, shave biopsy is done, but if it is a type of the flat lesion, morphea type or aggressive type, then biopsy is basically recommended in these type of the cases. During biopsy, deeper layer should also be taken to see the invasion. CT MRI radiological imaging is not done because it is said that squamous cell carcinoma is usually a locally invading tumor. So CT MRI is only indicated if you are suspicious that below the lesion there may be some bone destruction, there may be some cortical destruction, or you suspect that there may be some neural invasion. So MRI can be done in this type of the cases. Coming to the management point, management is basically depend on the at which site this lesion is present and how much cosmetically we can treat this patient. So histological variant and anatomical variant, these are the two basically factors which decide the management. Surgery is the standard of care. And standard surgical excision with clear margin is usually done in all the cases, but in few cases, most microscopic surgery is indicated. Our best aim should be that we should adequately initiate the treatment because the first chance of treatment is the best chance. Because if this type of the tumor recurrence, then these have the local destruction properties more, and they recur and they response are very less. These are the other treatment modalities we have: curate desiccation, standard surgical excision, micrographic, TDEMA. This is a kind of the standard surgical excision with more characteristic, more precise. Cryosurgery, local application of the immunomodulator like imiquimod, 5-FU application, photodynamic therapy, and the laser surgery. These are basically curate and the electrodesiccation. If this is done in a small superficial skin lesion, you can see at the ring shape this curate. So tumor is curated and simultaneously it is burned with ectophagy. But the side effect is it leaves a scar. So it is cosmetically not affected. Excisional biopsy is a standard of care. Usually it is said if lesion is less than 2 centimeters, then 4 millimeter margin appropriate. If it is more than 2 centimeters in size, then margin of the 6 to 10 millimeter is appropriate for this type of the standard surgery. Very large lesion may require the flap or skin grafting depending on the size of the lesion. Most micrographic surgeries, you have heard this name many times. This is basically done to conserve the tissue or to preserve the tissue so that cosmetic disfigurement can be stopped. Here, what is done that the gross tumor is excised and it is seen under the microscope. And all the four margins are observed. If it is found that this particular margin is positive for the tumor, then it is resized. And it is resized and again frozen section is in until we get the negative margin. You can see in this diagram. Yeah, you can see here that not whole tumor is excised. It is first excised and seen by microscope, positive margin, then it is shared. It is shared until we get the negative margin. So it is called very less disfigurement. It is most appropriate on the head neck side, like ear pinna, tumor is on the nose, the tumor is over the eyelid. Most micrography surgeons usually prefer this side. Another modality is cryotherapy, where the skin lesion is freezed by the liquid nitrogen, and it is suitable only for small superficial lesions. Again, it leaves a scar, so costly. It is not very acceptable modality. Photodynamic therapy, initially it was very basically fashion, no time, but now we are having the better technology, so nowadays it is rarely used. Here, what is done that some photosensitizer chemical is exposed, and after several hours, light is exposed. Photosensitizer agents like aminolevulinic acid lotion is applied over the skin side, or the aminolevulinic cream is usually applied, and then skin lesion is exposed to light. But it causes the inflammation reaction after 3 to 4 days, and treatment can be repeated after 7 days, and multiple sitting can be given until we get the result of this. It gives the excellent cosmetic result, but again I am saying that we have the better modality, so it is not usually done nowadays. Radiotherapy as primary thing is not indicated in case of the BCC if the patient is not a suitable candidate for the surgery, or if the patient is young, or if there is some comorbid condition where surgery is not feasible, and the patient is not willing for the surgical management due to some cosmetic or the function problem. Here the radiotherapy can be given. We have the many options for the radiotherapy. We have Western beam radiotherapy, the surface mold radiotherapy. We have the interstitial radiotherapy depending on the thickness of the tumor. Definitely, if we are giving the definite radiotherapy, then dose is 70 to 93 J. It is equivalent to BD10. If we are delivering the post-op adjuvant radiotherapy, in case we are not getting the positive negative margin after the repeated surgery, if we are suspecting any perineural invasion, if there is a positive lymph node, in these cases the adjuvant radiotherapy is delivered. If the extracapsular invasion is present, we have to give the up to 60 to 66 days of adjuvant radiotherapy. Local application, if very superficial tumor and depth is not more than 2 millimeters and the size is less than 2 centimeters in diameter, then local application immediately more acute with the radiation immune response modifier. It is applied. Usually each week 3 to 5 sittings is given, and up to 6 to 16 weeks it is applied. Similarly, FIFU, everyone knows that it is cytotoxin. This lotion and cream is available in the market. It is applied, but it causes the inflammation. So cosmetically, not very satisfactory result obtained. And apart from this, it has a high run rate. If there is an advanced basal cell carcinoma or patient with the metastatic, which is very unusual in case of the BCC, again, surgery is advised if it's advanced, followed by the adjuvant treatment. If it's the metastatic or the patient requires the adjuvant treatment, then target therapy, which is the HAZO pathway in that is Vismodegib and Sonidegib are available in the market. Vismodegib is basically FDA approved for the metastatic as well as advanced BCC, while Sonidegib is FDA approved only for advanced BCC. Coming to this slide, algorithm, just to summarize the thing for the basal cell carcinoma, if there's a primary tumor, then it's non-aggressive type and it's safely on lung or the extremities. Just do excision or electrodesiccation. If it is an aggressive type of the growth on the trunk or the extremity, then you need more precise of the treatment, either do the standard surgery or the most micrographic surgery. If the tumor is located on the some sensitive site like canthus, nasolabial, periorbital, where you cannot get the very clear-cut margin, white margin, you have to go for the most micrographic surgery. If this primary tumor recurs after the standard treatment, then most micrographic surgery is indicated. This type of the tumors. So this is all about the basal cell carcinoma. Now coming to the second variety, that is squamous cell carcinoma. It is generally said that is usually said that basal cell carcinoma has the property of the invasion. It is a local tumor. Squamous cell carcinoma has a tendency for the regional lymphadenode spread, and the melanoma has the tendency for the distant spread. So I'm covering like this. So now coming to the squamous, it is the second most common skin cancer in immunocompetent patient after basal carcinoma. But in case of the immunocompromised patient or the patient who has undergone the organ transplantation, it is the foremost common cancer, skin cancer. Usually squamous carcinoma present in the very early stage, and this is the good because it is a visible site, so most of the patients present in the early stage of the disease. So it has a good prognosis. And the metastasis potential is very low in case of the squamous cell carcinoma. This is the same as we have discussed in case of the basal carcinoma. Ultraviolet radiation is the mainly responsible factor, and it has a linear dose response association with this. Apart from this, genetic predisposition is also in case of squamous cell carcinoma. Light complexion patient, especially phototype 1 and phototype 2 type of personalities, more exposed to squamous cell carcinoma. Physical chemical carcinogen like cutting oils, patch, workers who are doing work in the chimney sweepers who are developing the scrotal cell carcinoma, scrotal skin cell carcinoma. So these are the risk factors which are more or less common, same as like the basal cell carcinoma. Incidence increase with the age, as I already said, that more the time of the sun exposure, so more the chance of the development of the skin cancer. So it is mostly seen in the patient of the who are more than 60 years of age. Male has the more tendency of developing squamous cell carcinoma. Sensitive results, red hair, blue eye, fair complexion, has a high propensity. Australian people from the New Zealand have the high chance of the developing this squamous cell carcinoma. Clinical features are variable and depends on the which histopathological type. Face and the head neck area is the foremost common site of squamous cell carcinoma, but we can see patients of squamous cell carcinoma coming with a digital lesion on the forearm, dorsum of the hand. Typical clinical finding is it is very slow, enlarging, and firm, and skin is usually colored from erythematous to a bluish color. Keratosis can be seen. Patient may present with ulcerative growth, exophytic growth, or infiltrative growth. These are the three growth patterns which we can see. You can see at the diagram that is a keratocanthoma type of the growth. This is the acantholytic squamous carcinoma. Spindle cell carcinoma, we can see here the pigmented, many times it is confused with the malignant melanoma. This is a dermoplastic type of the squamous cell carcinoma. It is a propensity for the metastatic, and it is very aggressive nature. Signature carcinoma, and this is the papillary type of carcinoma, which is just like cauliflower growth. So this is usually seen in our OPD. This is a verrucous carcinoma, which is usually seen on the anogenital region or the oral cavity or the amputation site. Verrucous carcinoma is a slow-growing, isolated, and exophytic type of growth. Coming to diagnosis, complete history and the physical examination is mandatory. In case of the skin carcinoma, patient must be asked about whether patient is having any trauma, how much such an exposure patient is having, what is his occupation, and the complete skin examination is mandatory. In squamous cell carcinoma, complete regional examination for the lymph nodes is also mandatory. Biopsy usually done as in the form of the shave biopsy or the punch biopsy. Punch biopsy very commonly done, and it is gives the accurate result. If you suspect there is a extensive disease and there is some underlying tissue destruction is there, then MRI or the CT scan is advised according to involved tissue. part, surgery again the standard of treatment in case of the squamous cell carcinoma. Though radiotherapy offers the equivalent excellent result in case of the early tumors. If the tumor is less than 2 centimeter or 3 centimeter and patient is not willing for the surgical management, so it gives the equivalent result in early cases. Again, the management of skin cancer is basically guided by the which type of cancer it is, what is the histological nature and what is the anatomical site of the tumor, and how much cosmetic or functional benefit we can give to the patient. Radiotherapy is usually not indicated in young patients due to the long-term side effects of the radiation. So in these type of the patient, surgery is the preferred modality of choice. Standard surgical management with clear margin is appropriate. Friends, you have heard the name of the in-transit metastasis, and many times you have heard the name of the satellite nodules. So let me give a difference, give a view of about this. Satellite nodules means if any skin nodule or subcutaneous nodule is present within the 2 centimeter periphery of the primary lesion. This is called the satellite nodules. If it is any subcutaneous tissue or the skin nodule is present behind the 2 centimeter of the primary lesion, but within the vicinity of the regional lymph node basin, then it is called the in-transit metastasis. We can say that the tumor is in the spreading form and it has not completely spread to the regional lymph node. This is called the in-transit metastasis and is usually seen in case of the squamous cell carcinoma, not in basal cell carcinoma. For the primary lesion, wide local excision with clear margin of the 2 centimeter is advisable. But if patient present with the lymph node, if it is solitary lymph node and it is less than 3 centimeter, then isolated selective lymph node dissection should be done. But if there is a more than 3 centimeter single lymph node, but it is more than 3 centimeter, or there is a multiple isolated lymph node, then complete R&D should be done. If there is a bilateral node, then complete bilateral R&D should be there. In case of the head neck, if there is a parotid lymph node is involved, then superficial paresthemy along with the split R&D is indicated. So this is comprehensive lymph node dissection. Now coming to the point, what is the basic point which you should look for the pathology report. So the histopathology report basically should indicate what histological type it is, because encephalitic, spindle cell and desmoplastic has a very poor prognosis. So histological type should be mentioned in the histopathological report. Grade of differentiation should be clearly mentioned, and the most important is the maximum vertical tumor diameter in millimeter, because it has impact on the regional lymph node metastasis. It should be clearly mentioned. Extent of dermal invasion, which is measured in class level, which I will complete in next slide, should be indicated. Whether there is a presence of a perineal invasion, vascular or lymphatic invasion is there or not, whether the margin is positive or not, all these should be seen by a radiation oncologist in the histopathology report of any malignancy, particularly skin malignancy. Now coming to the class level. What is the class level? Basically, this is the horizontal spread of the tumor. If it is only, if there is only epidermis involved, this is called the level 1. If there is the epidermis but papillary dermis is also involved, that is called the level 2. If the lesion is extending vertically up to the papillary reticular dermal interface, but is not crossing the reticular dermis, this is the level 3 class level. But if it is crossing the dermal interface and involving the reticular dermis, this is called the level 4 class level. And if it is involving the hypodermis, means it is involving the subcutaneous tissue, this is called the level 4 class level. Coming to the risk categorization, we know that our management depends on the risk categorization. So in squamous cell carcinoma, we categorize tumor into 3 groups. One is a low risk group, high risk group, very high risk group. Low risk means if the tumor is over the low risk location. Low risk location means if it is on the trunk or the extremities, or if tumor size is equal or less than 2 centimeters. If tumor is located on the low risk side, means trunk or extremity, but tumor size is more than 2 centimeters, but less than or equal to 4 centimeters. Or if it is situated on the high risk location. High risk location means apart from trunk and extremities. Then it is called the high risk. Very high risk, it is located anywhere, but tumor diameter is more than 4 centimeters. It will be considered as a very high risk group. Coming to the other management part, apart from the radiotherapy and the surgery, if tumor is very superficial and it is up to the class level 2, then topical therapeutic treatment, local application, immunomode, or the 5FU or interim 5FU also can be given. IS therapy, photodynamic therapy also can also be given, but this has a lack of evidence for this efficacy. So surgery is still a standard of choice. So again, I want to say that primary goal of treatment should be complete removal of the tumor with maximum preservation of the function and the cosmetic. And our treatment decision should be customized individual to individual. It should be basically individualized treatment. Coming to the radiotherapy part, in early cases, radiotherapy has the equivalent result as the surgery, especially brachytherapy, where the surface mold is being used. Brachytherapy is basically given in many forms. Initially, surface valve used, flap is put. If tumor thickness more than 1.5 millimeters, then interstitial therapy can also be used. Radiotherapy has an indication in an early lesion or patient is not desirous of the surgery. Apart from this, if patients adjuvant radiotherapy can be given in case of the positive surgical margin, if in post-op histopathological there is a perineal invasion present, if there is an invasion of bone, cartilage, or skeletal muscles. So these are the indications for the radiotherapy, and these are the dose schedule which is mentioned in the NCCN guidelines. If we are giving the radical radiotherapy and if the lesion size is less than 2 centimeters, then 64 gray is appropriate in conventional fractionation. Similarly, if the lesion size is more than or equal to 2 centimeters, then 66 gray in conventional fractionation is given. Then people used to give the 50 gray with the ERT exclusion therapy followed by the therapy boost. Most of adjunctive radiotherapies we are giving, it depends on the type of the reports. If it is a low risk type, then 50 gray is sufficient. If high risk features are present, like external extracapsular involvement is there, periapneal invasion, there then 60 gray can be given in adjuvant setting. Chemotherapy has a very limited data on this for the basically skin cell malignancy management. But now we are having molecular biology, these tumors, we are having the checkpoint inhibitor, we have the immunomodulator. So few chemotherapies are under trial. In case of the squamous cell carcinoma, EGFR inhibitors and the cisplatin can be given along with the concurrent chemoradiotherapy. We are planning on the radical radiotherapy sedation. Surgery is not an option. If a patient presents with a metastatic squamous cell carcinoma, then combination chemotherapy in the form of the cisplatin 5-FU carbo and paclitaxel can be given. Apart from this, PD-L1 inhibitors, Limab or pembrolizumab can be tried because all these are the trial, but no phase 3 study has been basically established their role. It is under trial. So it is not usually recommended. Coming to the prognosis part, as squamous cell carcinoma is basically residual tumor, so most of the patients present in the early stage, low risk group has a good prognosis and there is a high cure rate. But if the patient presents in the locally advanced disease with the multiple metastatic side, then prognosis is poor, and prognosis is very poor in case of the immunosuppressed patient. So now summary, if I summarize the things of the non-melanotic skin cancer, non-melanotic means basal cell carcinoma, squamous cell carcinoma. The thing is that standard of treatment is the surgery. If surgery is not possible, then we should go for the radiotherapy. Surgery has the basic main of standard surgical management. If this is the cosmetically worrisome point or the site is basically on the pinna or the nose or the ear lobule or the lip, then most micrographic surgery is the standard of treatment. Now coming to the another type, third one, that is the last one. This is the melanoma. Name already said, melanoma means dark. So it arises the melanocytic cell which is present in the stratum basal of the epidermis. It usually can occur anywhere where the melanocyte present, but the most common present site is the cutaneous skin melanoma, but also may present with the mucosal layers. Sometimes patients with present the oral melanoma, uveal melanoma, even GIT melanoma can be present. Meningeal membrane melanoma can also be there. This incidence is usually low, said that only 5% melanoma over of all the skin carcinoma, there is only 5% this malignant melanoma forms. But we when talk about the mortality, it costs near about 75% of mortality of the off-skin carcinoma. It means it is less incidence, but it is a very dangerous type of the malignancy. Risk factor, again the same, sunburn. If the person is having the repeated sunburn history or heavy sun exposure, fair complexion patients, blue or green eyes, blonde patients, blonde person. If the person is having the more than 100 typical nevi or any atypical nevi present, if the patient is having family history of the melanoma, all these are the risk factors for the malignant melanoma. Now, what are the signs symptoms of this? Melanoma can appear suddenly as a new mole, or it can develop slowly in or near existing melanoma. Sometimes it does not appear in from any other nevus. It is called a de novo malignant melanoma. If it is arise from any nevus, this is a nevus melanoma. So melanoma in male mainly found usually on the part between the shoulders and the hips, but it is the most common site is the lower. But it also be found in the shoulder which also you can see malignant melanoma under the fingers or the toenails, on the palm, on the soles, but most commonly over the shoulder and the hip region. Now, how to differentiate between the benign and the malignant nevus? So this is the rule, called the ABCD rule. You can compare both the things. In benign, you can see the symmetry of nevus is there, but in malignant, there is non-symmetry. You can see that this is asymmetrical type. So this is a malignant one. Borders are very even here, but in malignant melanoma, borders are uneven. You cannot define the border. Nevus, benign nevus is usually one color, but here you can see two or the more than two colors here. So this is the sign of the malignant melanoma. Nevus is usually smaller than 6 millimeter, or you can say this is a less than pencil eraser size. But if more than 6 millimeter in the size, or it is more than 1/4 of the inch, then it may be the sign of the malignant melanoma. This is the ordinary mole. It is not changing in size and the color. But if you are seeing that if any mole or any nevus is changing in size, in color, or if there is a itching present there, then it is a sign of the malignant melanoma. So ABCD rule must be basically remembered always. Clinical specificity depends basically on which subtype of malignant melanoma is. Superficial spreading, this is most commonly seen. This is found in 70% of the all malignant melanoma, and usually seen on the sun exposed side. Irregular border, you can see it. Irregular pigmentation, you can see here. Second is the nodular type of the melanoma. This is seen in 15 to 30% of the all melanoma. This is most commonly found in the trunk side. You can see that it is just localized, but it has a propensity for invasion. So, vertical invasion in more case of the nodular melanoma. So, this type of the melanoma is very dangerous. It has a very poor prognosis because of its invasive properties. It is not having the radical growth of the phase like superficial spreading melanoma. Lentigo maligna and lentigo maligna melanoma. Because these are the two misnomer terms. When it is in situ type, it is called the lentigo maligna, but when it goes into invasive pattern, it is called the maligna melanoma. Lentigo maligna is the most benign and good prognosis, while the maligna melanoma has the worst prognosis, but less than nodular malignant melanoma. Acral, as name already tells, that is usually seen on the palm and sole, and even black person can also develop this acral lenticular melanoma. Desmoplastic is a very aggressive type of the malignant melanoma, mucous melanoma. You can see over the mucous membrane of the lip here. A melanotic melanoma where the pigmentation is not there, so it is generally confused with either the squamous cell carcinoma or the basal carcinoma. It has difficult for the diagnosis, uncommonly seen. Only 5% of the patients you can see. Complication usually depends on the basically stage of the disease. If patient present with the metastatic disease, so the symptoms depend on which side of the metastasis. Patient present with the bone metastasis, patient may present with the pain, or bony fracture may be present. If brain metastasis, then patient may present with the headache, nausea, vomiting, convulsions. So symptoms depend on the site of the metastatic lesion. Diagnosis, same thing. First of all, if you see that if any mole is changing rapidly, evolving in color, increasing in size, there are more than two colors are there. If these two characteristics are seen in any nevus or the mole, it should raise the suspicion of the malignant melanoma. Complete skin examination should be done. Dermoscopy should be done. Apart from this, antibodies for immunohistochemistry for S100, HMD45, mutation for BRAF and RAS AKT, all this comes under the diagnostic part. For pathology, excision skin biopsy is recommended. Shear biopsy is usually not recommended in case of malignant melanoma. Punch biopsy is done. If the lesion is less than 2 centimeters, then incisional biopsy can be advised. But if it is more than 2 centimeters, then incisional biopsy should be done. If lesion is larger, present over the palm and shoulder, incisional biopsy is advisable. If lymph node is there, then ultrasound of that region followed by the excision biopsy should be done for confirmation of diagnosis. Stage 3 onward, malignant melanoma, complete metastatic workup should be done. Computed tomography, CT thorax, abdomen, MRI of the region from where this skin lesion is present, and in a few cases, if required, CT scan should also be done. Stage 2 onward. Now coming to the breast flow thickness, these are the some points which should be basically taken into account in the histopathological report, because malignant melanoma prognosis basically depend on these 3 points. One is the breast flow thickness, ulceration state, and dermal mitotic rate. These are the 3 most important points which should be remembered for the prognosis and the treatment to deciding the treatment modality of the malignant melanoma. Apart from this, deep and little margin status should be assessed. Presence of the microsatellite should be assessed. Desmoplasia, where the mixed or the pure desmoplasia, lymphovascular invasion is there or not, if there is a perineal invasion present or not, it should all seen in the histopathological report. Now coming to the class level, we have already covered. Initially, class level was included in the TNM staging and other staging system, but nowadays the current staging system is basically dependent on the breast flow of the invasion. If there is an invasion less than 1 millimeter, this is level 1. If it's 1 to 4, this is level 2 of invasion. If it is more than 4 millimeter of the vertical invasion, dermis invasion, then it is called the level 3 of breast flow. Coming to the TNM staging, I have covered TNM staging in case of the squamous cell carcinoma. I am covering here because I just want to give the emphasis that this is the tumor where the depth, thickness is taken into account. In case of squamous cell carcinoma, it is the basically size of the lesion. If it is less than 2 centimeters, this is T1. If it is 2 to 4, this is T2. It is more than 4 centimeters, then it is T3 or T4. But in case of the malignant melanoma, this depends on the breast flow thickness. If it's less than 1 millimeter thickness, this is T1. If it is 1.01 to 2 millimeters, this is T2. If it is T3, it's 2.01 to 4 millimeters. But the thickness, breast flow thickness is more than 4 millimeters, it counts as the T4 lesion. Here, AB subcategory is done depending on the whether ulceration is associated with tumor or not, and what is the mitotic figure. So these basically thickness, again I am saying thickness, ulceration, and mitotic figure. These are the 3 most common points which should be taken into account while deciding the prognosis and deciding the management part. Nodal, if there is the one node This is N1, 2 to 3, or this is N2. It is 4 or more than 4, then it is called the N3. Here, agar micrometastasis is present in the pathological examination, should be detected as A type. If it's macrometastasis, you can clinically, it is clinically visible or radiographically visible, that it is called as the macrometastasis. It is to be detected as B subtype. Metastatic, that is unphased, if it's distant skin subcutaneous or node. It is A. If it is lung metastasis, it is 1B. If it is all other sides, distal metastasis, it is counted as a 1C. Here the point to be noticed is that serum LDH is incorporated in metastatic phase only, not in T and N phase. So this should be remembered. Coming to the management part, again the standard of treatment is wide local excision. If there is the in situ malignant melanoma, then 0.5 to 1 centimeter clear margin sufficient. If thickness is 1 millimeter, then 1 centimeter margin clear margin sufficient. If there is a thickness of 1 to 2 millimeters, then 1 to 2 centimeter clear margin is appropriate. If breast flow thickness is more than 2 millimeters, a margin of still 2 centimeters is sufficient.
Patient
It is now clear. It is now clear that taking margin more than 2 centimeters has no impact on the prognosis. So 2 centimeter margin is sufficient in malignant melanoma. Standard of therapy for macroscopic, that is stage 3 and stage 3C, where the macroscopic lymph node is present, complete lymph node dissection should be done, depending on the which site of tumor is. Prophylactically, dissection is nowadays is not indicated because we are having now facilities of the sentinel lymph node biopsy. If on sentinel lymph node biopsy macrometastasis is present, then we should go for the complete dissection of the lymph node. If it is negative, there is no need for the complete lymph node dissection of the site. If it is in the lower part of the genital region or the lower part, and complete broad dissection should be done. Deep inguinal lymph node, deep iliac lymph node, and superficial inguinal lymph node should be removed. If it is over the axillary region, if the draining side is axillary region, the complete level 3 up to the level dissection should be done. If it is in the head neck region, along with the region lymph node, superficial periodectomy is mandatory in this type of the malignant melanoma cases. In transit disease, basically hyperthermic isolated perfusion is a good modality for this type of the patient. What is isolated hyperperfusion? Here the lymphatic vessels, the blood vessel of the site involved is isolated from the regional site, and the high dose of melphalan is infused at high temperatures, approximately 41.5 degrees C, and it is perfused up to 60 to 90 minutes. We see that it has the high rate up to the 50%, but if we add the therapeutic factor alpha or interferon alpha along with the melphalan, then we can get oxygen rate up to the 90%. After the treatment, then the artery supply of the limb is again reconnected. So this is a very fascinating type of the treatment. Coming to the target therapy, the BRAF inhibitors are nowadays available. The Bemofarabinib drug is there, KIT inhibitors like imatinib is available, but all these have a little bit result in case of the metastatic malignant melanoma. As per NCCN guideline, combination of checkpoint can be used in case of the advanced malignant melanoma as a adjuvant treatment, or in metastatic setting, nivolumab, along with ipilimumab, anti-PD-1 inhibitor as a monotherapy or the combination chemotherapy can be used. If the patient is not able to afford these high molecular antibodies or the immune check inhibitors, if not responding to these high drugs, then chemotherapy also can be given, which has a little bit 20 to 30% of the response. For the dacarbazine drug of choice in combination with cisplatin, paclitaxel, docetaxel, and temozolomide. In few cases, it has some impact. Immunotherapy also has a role nowadays. BCG, one study has shown that Mycobacterium indici prami, if gives a lesion, it has a good result in case of the advanced case of the malignant melanoma. From this monoclonal antibodies, tumor vaccine also, but all are under trial and no phase 3 clinical data is available for these. Coming to adjuvant therapy, after the proper surgical management, if there is a positive high-risk group or the positive margin, then adjuvant therapy can be given or adjuvant interferon alpha, anti-ELF4 antibodies, antigen. But adjuvant radiotherapy is basically given in case of the complete lymph node dissection to cover the regional lymph node. Because the malignant melanoma generally said it is a little bit radio-resistant type of the tumor, so its efficacy is little bit doubtful. But in case of the palliative setting, high dose subtraction can be given to palliate the symptoms of the pain or the case of the bleeding if the patient present with the fracture. So in this case, the palliative radiotherapy is given if patient is not a candidate for the surgery or then radiotherapy can be given the high dose subtraction or the hyposection schedule in some cases, just in the trial basis. Coming to the surgical management, to summarize all this, again, I just want to say that if the thickness is more than 4 millimeter to centimeter, margin is sufficient. Then if the thickness is more than 4 millimeter, then further metastatic workup should be done. This is the treatment algorithm for stage 1 to wide local excision with clear margin. Stage 3, complete regional lymph node dissection should be done. For the stage 4, if there is the oligometastasis present or single or 2 or 3 in a single compartment is present, then solitary metastasis oligometastatic can be done, followed by the systemic treatment, which I've already told about this. So this all is about the treatment part. Coming to the prevention part, we have discussed the only positive factor, only positive thing is the sun exposure. So protection from the skin is the foremost preventive measure for these skin carcinoma. Stay indoors or under the shade. If you are outside, wear full sleeves clothing, apply high SPF and protection cream. If you are going outside, avoid sun exposure during the 11 to 2 because this is a very harmful time and this is very harmful period for sun exposure. Avoid indoor tanning because few people use the tanning bed or sun bath. This should be avoided. And these are the 5 protection skin slip, flop, flap, feet, and slide for the protection of the skin tumor. Thank you so much. Thank you for patience with me.
Thank you, Dr. Surbhi, for your nice presentation. You have explained everything, starting from anatomy, pathology, staging, type of malignancies, squamous cell carcinoma, basal cell carcinoma, melanoma. Such a vast topic. We are thinking that skin is a small part, but it includes very vast area. So, and you have nicely covered everything. Anji?
I just want to say, even one carcinoma has in a full chapter, and malignant melanoma is also very vast chapter. It cannot be included.
Yes, it's very vast. Nowadays, MyCDEC C, as you know, it has also come. It is also playing some role in squamous cell carcinomas and melanomas. I don't know. The trials are going on. I don't know how far it is true. But it works. Earlier, we used to use this new VEC, if you remember.
Yeah.
It used to come like new VEC, and it was a subcutaneous injection. At that time, it had a lot of problem, and then it was discontinued. And now they have come up with a refined form of MyDEC C, and it has been it has claimed a very good result in many malignancies. So it is under trial. And we are also using it, and let us see what it come out. So it's a very nice presentation. Any question from the participants?
Ma'am, kindly unshare the screen. Stop sharing the screen.
Kindly unmute yourself and put your
Dr. Chaturvedi, your face is not being seen. So
okay.
just lift up yourself. And it is blurred, lens is blurred.
Okay, fine.
So final pick, at least let it be better.
Okay.
So it was really a very wonderful session and got a lot to learn. And we also know that so many basal cell carcinomas we have seen during Doc Saab's practice and resolving by chemo. But
Oxygen and look like
excision and chemo. Excision and chemo.
radiation.
And followed by radiation, definitely. But sometimes we saw a small skin cancer leading to metastasis somewhere else. If you remember, when we were in the last place, there was a senior person who died because of that only.
Yeah. One doctor died because of he was having chronic dermatitis in the finger, and they said nothing, it's nothing. I said, Doctor, you get yourself checked. He said nothing. We have done step biopsy. So the role of a step biopsy is very dubious, very deceptive. You must go for the incisional biopsy and go and get it checked. And that small lesion, it led to multiple metastases in axilla and liver and all, and ultimately died of that particular thing. So one should be very careful in
That
diagnosing.
we had become so much over conscious that then we had a relative who had a small little bit here near the
It's better to be
angle
overcautious
of,
rather than undercautious.
yeah, I got that removed and the surgeon was saying, yeah, unnecessarily overthinking, you know. And then he was saying, "Ki, just get a cryo or something done." He said, no, remove it from the root itself. So it was completely removed and the patient survived till now. There's no problem. हालांकि उसमें cancer तो नहीं आया था, but there was some other diagnosis, maybe pre-malignant lesion or something.
One should be very much cautious. And
Because it was, you know, melanoma type, black. And less than 1 centimeter, definitely got that removed. Anyway, so there are many lessons to learn practically and academically also we keep learning every day. Thanks to you, Dr. Surbhi. And any other queries or any you have practical experiences through your cases, you can share with us. And people would love to hear more from the academics than the practical than from
Yeah, I
the
just want to share. I just want to share one treatment. I'm not having pick up that patient this time. Initially, we were doing the mole therapy. No, but nowadays people are not promoting that. One patient of basal cell carcinoma came to me. It was superficial spreading type, and it was near 10 centimeter in size. And he was not willing for surgery because 10 centimeter over the face, obviously it's probably the discrepancy, and patient needs for the flap reconstruction. So we did customize that more implant in that patient. We gave 6 gray pulsation BD up to 4 days, and that patient has excellent result, and without pigmentation. So
very good.
Still, all these old modality have a very good response, but I don't know why people are not promoting due to the high technology.
And what about that patient which I had seen long back? आप ही का मरीज था, Dr. Chaturvedi. In the abdomen, he had a melanoma, skin cancer, which we got surgically removed, and immediately within 6 months or so, again there was a recurrence.
Melanoma, they are very notorious tumors. They metastasize so fast. So before treating melanoma or before going for any drastic treatment, you should do a complete workup so that you may come to know whether it has already metastasized or not. Because it commonly
local recurrence was there. Local recurrence, if you remember.
Yes.
वो इस जंगल में काम करता था. He was a person. So sun exposure was too much. That history was definitely there. So now all those who say Surya Pranam, to Surya Pranam Brahm Muhurt mein. ये नहीं कि दोपहर के धूप में. So all of us should remember that take home message that वैसे भी इंडिया में कम है skin cancers because of the good effects of the melanin. As I went through the Google and PubMed, I could come to know that. But still, if we are exposed too much,
we have got less incidence because of this.
yeah,
The skin is giving
So,
good protection against
protection.
UV. Yeah.
So 5 minutes exposure only is sufficient for dark skin people, and fair, they can have a little more. So accordingly, they have said sun exposure. और वो भी सुबह के time. This is the take home message to prevent cancer and have good food, good diet, and be happy and do good exercise mentally, physically be fit. Don't do too much of anything. That is the best thing.
You can
Dr.
do
Surbhi.
molds at your center. Now I think you got microselectron at your center.
Okay, so we were having, but it has end life, so it has been decommissioned. Microselectron.
Okay.
So it is not of use, yeah.
Oldest institute, and it was known just like Indore Medical College. They are contemporary, and they were the only centers which were having cobalt, radials, and all the molds, tubes, and needles. So now I don't know. Now it has. What about your Linac? Has it come or installed?
Linac is under pipeline. Yeah, I mean, it is in pipeline, so most probably within 2 to 3 months we will have it. Versatility.
So good. All the best.
Thank you.
Install it
Even
soon.
Electa has also, yeah, Electa has also introduced some applicator for the skin malignancy tumors, the lip-based applicator type of things. No? They have introduced.
So you will be buying, you are on for Electa, not Trubim.
It's a government set, no, so they are going for.
PMSS scheme, ma'am, under.
That's the problem.
Sure, that's nice.
Thank you very much.
Really had a very good talk.
Very nice presentation.
Thank you, sir.
And thank you, Dr. Surbhi, Dr. A.K. Chaturvedi, Mr. Ujjwal Parekh, and all the lovely audiences, Mr. Aditya, Aishna, Dibyanjan, Kundu, Shivani Malik, Dipanshi, Devansh, Pratibha, Singh, Galaxy, Nidhi, Renu Singh, Shah Alam, good to see you all. Shailendra Dikshit, Shyam Kumar, Tripti Sharan, Vivek Khare. Nice to see you all and being a lovely audience. And thanks to our technical team for carrying out the whole session without any itch and hesitation and without any interruptions. Thank you so much, and I would like to have screenshots and the recording to put over my group. Thank you very much for the sudden change from the old technologies to you. Thank you so much. Thanks all. We'll meet tomorrow again for the second live webinar where Dr. Rashmi Shukla will be speaking on awareness of breast cancer, role of early detection in breast screening, role of breast screening in early detection. So all of you please join tomorrow again. It would be really to see you, really be very nice to see you all again. Thank you so much. Okay, good night.
Thank you, Doctor. Thank you, Doctor, for the great initiative. Thank you, Dr. Surbhi, for
thank you all.
Presentation and
Thank
really
you.
great.
Okay, thanks.
Bye-bye, madam. Thank you.